Medurstand, Understanding Medicine.
I'm Professor Azizur Rahman, and I'm also Senior Vice President, Pakistan Society of Internal Medicine. Currently, I'm Professor at Rashid Latif Medical College. Today, we're going to talk about this very important subject called HbA1c, the true interpretation. So, I have this agenda listed here. So, first of all, what is HbA1c? Its diagnostic value, its monitoring value, and limitation of the test. And then at the end, I will present some case scenarios and see if you have understood the message well. So I think this is going to be interactive session. Of course, I will not be able to actually talk to you, but I will give you a pause. Whenever a question is presented, I'll give you a few seconds to ponder and to come up with an answer. First of all, first of all, what is HbA1c? This is an RBC, and our RBCs, they do not have any nuclei. They do not have many organelle also. It is just simple bag full of hemoglobin. So I think other than matrix, it's just hemoglobin. And hemoglobin is of three types. About 97 and 98% is hemoglobin A1, which refers to the adult type hemoglobin. We have also hemoglobin A2, just maybe 2% or less. Then there's a hemoglobin called hemoglobin F in adults also, although this refers to fetal hemoglobin. But in normal healthy person, less than 1% fetal hemoglobin is present. All are different types of hemoglobins. They differ from they all have alpha chains, but the second chain is beta or gamma or delta. Uh, Whenever there is glucose in the blood, and of course there is some glucose always, and there is a hemoglobin always. So these two molecules, glucose and hemoglobin, they tend to bind with each other. And this binding is irreversible. Once glucose is bound to hemoglobin molecule, this change will be irreversible. This will become a glycohemoglobin. But the oxygen carrying capability of hemoglobin will not change. Although it would have some physical change in structure and it can be measured separately, but it would continue to be hemoglobin. And this is non-enzymatic binding of glucose molecule with N-terminal of beta chain of heme. Now, important thing is that this is non-enzymatic. That means because enzymatic processes are very quick and complete. This is a very gradual, very passive phenomenon. But whatever hemoglobin is converted into glycohemoglobin, that is irreversible. And you need to have beta chain. Of course, we have beta chain, but people with beta thalassemia, their beta chain may be less in quantity and their HbA1c may not be a very accurate measure of glucose. So we measure this, and there are actually three types of hemoglobin, glycohemoglobins, hemoglobin A1A or hemoglobin A1B and hemoglobin A1C. Most of this glycohemoglobin is hemoglobin A1C. So we normally take hemoglobin A1C as representative of total glycohemoglobin. So for practical purposes, we just talk about hemoglobin A1C. Some people also call it just simple A1C, and Americans call it AIC also. Now this is an RBC full of hemoglobin, and depending upon the level of glucose in this patient and also the duration of glycemia, some of hemoglobin molecules are converted into glycohemoglobin, hemoglobin A1C. Now RBC has a life of 120 days on the average. So since this is an irreversible phenomenon, so this HbA1c will continue to be measured as HbA1c as long as this RBC lives. So since this RBC is going to live approximately 120 days, and that is why we say that HbA1c represent the glycemic status of the last 3 months, 3 to 4 months. Now, these are two measures. These are conventional measures which were used in DCCT trial, and this is measured in percentage, like 6.7% of total hemoglobin would be A1C, like that. But these days, they are being replaced with this new units. These are called millimoles per moles. Now, these are important because they are more precise and they have been adopted by International Diabetes Federation, American Diabetes Association, and European Association for the Study of Diabetes. All major societies, they have already accepted this new method of new measure, but in Pakistan we still follow this one. You can have some idea, although some apps are available and formulae are available. You can convert a given percentage of HbA1c into millimoles per moles, but some laboratories give both values. You can use this chart or you can use an app to convert percentage into millimoles or reverse. And you can actually have an idea what is the average amount of, or what has been the average amount of glucose in this particular person during the last 3 months. So if somebody has HbA1c of 7%, his average blood sugar, including fasting, random, nighttime, so average per 24 hour is 154 milligram per deciliter. Why it is important, this is the question, and you have the apps also, but you can use this equation. Now I think 10% of HbA1c might not have any impact on the patient, but if we convert this 10% into average glucose, and if you tell your patient that your average sugar has been 240 during the last 3 months, so I think it would have a greater impact. And also for the physician, it is, I think, good idea to have HbA1c converted into average glucose to have better understanding how bad or good the glucose level has been. Now we have done with what is hemoglobin A1c and what is the diagnostic value that we are going to take up now. Hemoglobin A1c was previously used for monitoring purposes only. It was not used for the diagnostic purposes. But I think since 2010, we're using HbA1c as a diagnostic criteria also. Because it provides very simple, convenient one-time test and it tells you the exact status of the patient. In a normal person, we expect hemoglobin A1c to be less than 5.7%. Please note down, 5.7 is not considered normal. It has to be any value less than 5.7. It can't be 0. It has to be somewhere like 4 because everybody has glucose. A healthy person also has certain amount of glucose. So it would be like 4 to 5.6. So that would be normal. But if one single value of hemoglobin A1c falls between 5.7 and 6.4, including 5.7 and 6.4, he would be classified as a patient of pre-diabetes. This is actually diabetes in the making. Process from normal to frank diabetes is progressive, and within certain range you also have various levels. So 5.7 is pre-diabetes, 6.4 is also pre-diabetes, but this one is very close to normal, this one is very close to diabetes. Now, if somebody's measured HbA1c is 6.4% or more, just one reading, irrespective of the meal, just one reliable reading of 6.5 or more, then patient is classified as diabetic patient. So it has got great diagnostic value, very simple, straightforward. One test which is irrespective of the meal time, one reading gives you the exact status is if this is normal or pre-diabetes or diabetes. And appropriate action can be taken accordingly. So now let's take up this third agenda item, that is monitoring value. A few basic points. It is typically done every 3 months. Once patient has been diagnosed with diabetes and he has been started on medication and lifestyle changes, and typically HbA1c is done every 3 months, because we have already discussed that it represents 3 months average. Now be very particular about the lab, because even in America, all laboratories are not standardized to do HbA1c. So in Pakistan, we have some laboratories which are very reliable, but some other are not that reliable. So I think you have to be very sure that HbA1c comes from a good laboratory and does not replace blood glucose monitoring. We have HbA1c every 3 months, or maybe sometime every 6 months. A patient is doing very well, but it does not undermine the importance of glucose monitoring. Glucose monitoring is still very important because it gives us additional information. It gives us instant value. Now, may not be done if blood glucose values are high. Of course, if you do HbA1c in somebody whose blood sugar values are high, but then you expect HbA1c to be high also. So no additional information is obtained. So I think best time to do HbA1c, since it is little expensive test, so I think best time to do an HbA1c is when somebody has been on stable medication for 3 months and his blood sugar values have been reasonable. And only then we can expect that HbA1c would be reasonable. If he has not been on stable medication during those 3 previous months, if patient has been changing various medication, then I think HbA1c will not give us very useful information. And if his blood sugar values have been very high, again HbA1c might not give us any additional information. It will just confirm that hyperglycemia has been very bad, but it will not give you any additional information. So I think if you want to make best use of money, and if you want to make the best use of this test, once patient is on a stable medication and his blood sugar values, blood sugar done at home, are reasonable, close to normal, I think that is the time to do HbA1c. Now if somebody's fasting sugar is like 100, that is very good, but if A1c is high like 7.5, that would mean that his postprandial sugars values are high. May not give a reliable value if patient has some blood disorder. There are several disorders which can change the value of A1c. For example, patient with thalassemia, patient with hemolysis, patient who are on hematopoietic stimulating factor, and patients who have received some blood transfusion, patients who have recently lost some blood. These are the patients where A1c may not be very reliable. This slide explains two important concepts. One is the effect of early versus late hyperglycemia on HbA1c. Now, for example, this is the 3 months period, and this is the time when we do HbA1c. The effect of previous 3 months is not actually uniform. As we see from this chart, the previous first two months may have less impact, but the last 2 or 3 or 4 weeks have greater impact on HbA1c. So it is possible that patient's glycemic control was not great. Only during the last 2 or 3 weeks he intensifies his control and his HbA1c came out to be quite good. And reverse is also possible, that his glycemic control was quite reasonable, but only during the last 3 or 4 weeks his glycemic control was poor and that increased his HbA1c. And the second concept is the effect of fasting versus prandial hyperglycemia. Uh, for example, this is the spectrum of HbA1c. One can have very high HbA1c like 11% or more, or when we treat him, we bring him back to like 7% or less. So initially, we have to focus on fasting hyperglycemia because more your HbA1c, more is the contribution of fasting hyperglycemia. But when we get close to 7 and when you want to achieve a very good glycemic control, you aim to achieve 7% or less, then you have to focus on prandial glucose. The contribution of glucose after the meal is more and more when we get close to 7% or less. So these factors are important because of course whenever we treat patient we address both fasting as well as prandial glucose, but there are some therapies which specifically address fasting glucose. So when we want to achieve a very good glucose control, we have to consider prandial hyperglycemia also. Now, in monitoring, what is our goal? The goal actually depends upon these factors. If patient is younger and patient has relatively newer diabetes, very short duration of diabetes, and no comorbidities, less prone to hypoglycemias, and patient has got more life expectancy, so then we aim for a tighter control. We aim for a HbA1c of 6.5 or less. But if patient is older and has got long-standing diabetes mellitus and has many additional comorbidities like kidney disease, like heart disease, and is particularly prone to the bad effects of hypoglycemia, and life expectancy is already limited, then we are less stringent and we go for lighter control. Why so? Because tighter control in this group may actually increase the chances of hypoglycemias, and these patients are very vulnerable to the bad effect of hypoglycemias. Whereas these patients are not very vulnerable to hypoglycemia, their body homeostatic mechanisms are better, so they may not develop hypoglycemia very frequently, and even if they do, they can tolerate it better. Now, I would like to make one point here. No matter what we do, no matter how careful patient is about eating or exercise and weight, and no matter how many medicine we use, it is almost impossible to get to normal HbA1c and stay there. So it's basically a compromise. We have made certain aims which are possible to achieve without the risk of hypoglycemia, or at least with acceptable risk of hypoglycemia. These are various values. American College of Clinical Endocrinologists and International Diabetes Federation, they have given the value of 6.5 for majority. And of course, the aim would vary depending upon the factors I discussed in the previous slide, but their goal is less than 6.5. American Diabetes Association and European Association for Study of Diabetes, they have jointly issued a statement and they say for majority 7 or less is good enough. But of course, they say if patient is younger and is not having any comorbidities, we must try to achieve a better A1C like 6.5 or 6 or maybe even normal less than 5.7%. Those patients who are slightly elderly and ADA and ESD say that even 7.5, 8% may be acceptable. Even sometime more than 8% has to be accepted if patient is very, very fragile, patient has got heart problem, kidney problem. I think interesting recommendations are from American Society of Physicians. So American Society of Physicians, American College of Physicians, they have given the value of 8% or less. Now they have made a point that bringing A1C down from 8 to 7% requires many resources, and it adds to the cost and the risk of hypoglycemia. And they have noticed that the benefit is the additional benefit is not actually too much. So they say even 8% is good enough. So I think depending upon your practice and your patient, you could make any aim, but I think 7% or less is most widely accepted goal. Now, comparison of common monitoring techniques. We have three main monitoring techniques. We have plasma glucose. We can have it from the laboratory, or we can just self with the device we have at home. These instruments, the home monitoring devices, they can measure glucose with plus minus 10% accuracy. So I think the first diagnosis of diabetes should not be made on home monitoring, home values, because 10% difference could actually change the category from normal to pre-diabetes, or from pre-diabetes and diabetes. So I think, but for monitoring it's great. When you are monitoring sugar, if it is like 250 or if it is 230, in both cases sugar is high and the action is the same. HbA1c, either from the lab, or these days we have some devices where you can have the HbA1c measured at the point of care also. It just takes about 10-15 minutes. So that's a very useful test. Then continuous glucose monitoring, which is very, very useful but expensive. And I'm going to discuss these three things, their merits and demerits. Plasma glucose gives you instant value. Whenever you check the sugar value represents that particular moment's status. And it is particularly useful to detect hypoglycemias, because hypoglycemia are very dangerous. And whenever you suspect hypoglycemia, this instrument, the device, provides the opportunity to check your sugar and immediately confirm if hypoglycemia is present, and it allows you to take immediate action. Now, it also allows you to make appropriate adjustment in medication or in insulin. For example, somebody's fasting sugar is normal, but afternoon sugar is too high. Then I know if patient is on insulin, the insulin he is taking in the morning needs to be increased, and the one he takes at night is okay. So I think monitoring of glucose is very, very useful, and it is very cheap and readily available. Devices are not expensive, and you can just move to any pharmacy. They also offer this test. So I think glucose monitoring is very, very useful. HbA1c has again some good points. It gives you the average value. So even if sometimes instant value is okay, somebody's blood sugar fasting may be okay, but average may be high, and that would be reflected by HbA1c. And it is meal independent. Glucose value has to be related to meal. Value for fasting sugar is different, and value for post-prandial is different. Whereas you, irrespective of meal, patient can have that test anytime. And it is just one value which is diagnostic. You don't have to repeat the test again and again, but there are some caveats, and I have actually mentioned them earlier. So you must consider those caveats when you are making a critical decision based on HbA1c. Continuous glucose monitoring, you can give multiple readings per day. It's like having a watch, and seeing the time whenever you want. It gives you the trends of glucose when the glucose is going up or coming down. It can actually give you the warning of hypoglycemia, very accurate average, and it is very, very useful in type 1 and also useful in those patients who are on insulin, type 2 diabetes, and especially the one who are very brittle. Their blood sugar varies widely, but they are expensive and tedious. So every monitoring technique has its value. I think mostly we do these two: self-monitoring of glucose and occasionally laboratory monitoring of HbA1c. So this was the role of HbA1c in monitoring of diabetic patient. Now let's discuss the limitation. Number one, I think that test has to come from a reliable lab. Of course, some labs are formally standardized by the regulatory authorities, but we just go by the face value. If somebody, some laboratory is known to be a good lab, we tend to trust their report. Now, it gives you only the average value. Now just note down that average of 49 and 51 is 50, and average of 1 and 99 is also 50. So if you go by average, both these situations will look alike, but actually there's a lot of difference. So this patient has got very little variation. His sugar is fluctuating around a very around an average very narrow margin, and this patient has got gross fluctuation, although he has come up with the same average. So this is of course a gross example, but average sometimes may not reflect the true status. The true status is actually shown by the continuous glucose monitoring. Then RBC lifespan and hemoglobinopathies. In certain hemoglobinopathies, those which affect beta chain, the HbA1c may not be very reliable. And if somebody's RBC lifespan is different than normal, either he or she has some hemolytic process or he or she has vitamin B12 deficiency where RBC span may be longer than usual. So I think that could also affect hemoglobin A1c value. If somebody has a permanent problem, like somebody has beta thalassemia minor, of course we can still use A1c in those patients because HbA1c will still tell you the trends if the HbA1c is becoming better or getting worse. Then it does not detect glucose variability, as I discussed in this example. So there could be a lot of variation in glucose and still the average may be same. So these are the limitations of HbA1c. It is very, very useful test, but every test has some limitation, and I have highlighted some of the limitations of HbA1c. Now we are going to discuss some case scenario to just help you better understand the value of HbA1c. Okay, case scenario number one. An asymptomatic 38 years male person comes for your opinion after having following test. His blood sugar fasting 8 hours overnight is 112 milligram per deciliter. His blood sugar random measured 2 hours after starting meal, which is actually post-prandial glucose, is 138 milligram per deciliter. His HbA1c is 5.4%. What do you say? What will you tell this patient? Is he normal, or does he have pre-diabetes, or does he have diabetes? Now, all three values may not be concordant. Sometimes there is some disconcordance in these values. So if you go by HbA1c, 5.4 will be normal. And if you go by blood sugar 2 hours postprandial, this is also normal. Now, fasting sugar is not normal because fasting sugar was expected to be less than 100. What do you say? I give you 2-3 seconds to think about. Would you agree if I say this patient has got pre-diabetes? If that is the case, then why HbA1c is 5.4? It is possible that he has developed this pre-diabetes only very recently, within last maybe 1 or 2 months, maybe just 1 month, maybe just few weeks. So his fasting sugar has gone above normal, whereas his HbA1c is still normal, or he has one of those conditions where HbA1c does not give you the true status of glucose. So you have to actually ponder. I think if patient has got blood sugar and A1c and both values they do not tally with each other, it is the standard practice to either believe the bad value, so you may take some action based on this value, or you repeat this value. If repeat test also shows blood sugar very similar to 112, then the final decision is made on this basis. So if that turns out to be the case, this patient should be labeled as a case of pre-diabetes. Now, of course, we may not start medication, but this patient must be explained what is pre-diabetes, and he must be given due instructions to change his lifestyle, his diet, his exercise, his weight management, because this is only diabetes in the making. If nothing is done, this will become diabetes. So this should not be ignored, and patients should not have false assurance based on normal HbA1c. Case scenario 2. A 49-year-old non-diabetic and on regular medications comes with the following recent reports. Blood sugar fasting ranging between 140 and 200, and he has his own device. These are home measured values. The values have been ranging between 140 and 200, multiple readings, and his blood sugar random has been ranging between 180 and 290 milligram per deciliter, and he's got multiple value. And how useful you think and how crucial is HbA1c to decide the next treatment course? Sometimes we have to take a critical decision. You have to add oral medication or you have to consider injectable. That is very important decision. Consider patient perspective. So this is going to be a very, very critical decision. You think HbA1c is going to add anything to the impression? The impression here is that his blood sugar is not controlled at all. Multiple fasting sugar values, multiple random sugar values are clearly above normal. So in my opinion, HbA1c being an expensive test may not be done here. It is not going to add any useful information. We already know that this patient is uncontrolled, and whatever treatment patient has been prescribed, either he's not taking or it's not working. So you definitely need to take next action. Now, if patient desires to have HbA1c, you can do it, but it is certainly not going to change my impression. I know it already that patient needs to, next action is to be taken. So since this is an expensive test and it is also time consuming, if patient has come for a visit today, and if you order A1c, he will have to come again tomorrow. So that is another practical issue. I think you can make a decision on the basis of these values. So in my opinion, A1c might not give you any additional information. What would be the best time to have the HbA1c repeated? I said once blood sugar fasting, blood sugar random are reasonable, then you can repeat the test. A1c, but not earlier than 3 months. Now, this is case scenario 3. A known diabetic for the last 10 years on oral anti-diabetic therapy comes with the following labs. HbA1c is 6.9%, which is within the goal. Blood sugar fasting 112, and our goal is to keep fasting sugar between 80 and 130, and 112 is within the goal. His serum creatinine is 1.2 milligram per deciliter, and estimated GFR based on his body weight is 90 milliliter per minute per 1.73 meter square surface area. This is also quite good. So he apparently is doing very well. But he also has urine test, and urine complete examination shows 2 plus glycosuria and no sediment. Urine examination shows no evidence of any kidney disease because there is no sediment, but just one abnormality, that is 2 plus glycosuria. Normally we have glycosuria when our blood sugar exceeds our renal threshold, which is 180. So from 2 plus glycosuria, you might consider blood sugar to be around 250 or even more. But his blood sugar is very good and his A1c is also very good. What do you think is the explanation of this 2 plus glycosuria with very good control of diabetes? I give you 2 or 3 seconds to ponder. Would you like to go through the patient's prescription? Is there any drug which could be causing this glycosuria? Yes, SGLT2 inhibitors. These are relatively new drugs. What they do is they prevent reabsorption of glucose from the renal tubules. So they are actually, these drugs are causing glycosuria to bring glucose down, plasma glucose down. So this patient may be taking one of those SGLT2 inhibitors. We have empagliflozin and we have dapagliflozin. They're very, very popular drugs because of their unique benefits on weight and on renal outcome and on heart failure. So these are very popular drug. So I think most probably this patient is taking one of those SGLT2 inhibitors, or if he's not on any SGLT2 inhibitor, maybe then he has what we call renal glycosuria. So would you readjust his medication in view of glycosuria? No, because glycosuria does not really matter. What matters is blood sugar and HbA1c, both are quite acceptable. So we will just explain to the patient that this glycosuria is the effect of medication and you need not worry about it. And how will you explain that disparity between blood and urine tests? And this is actually, I have already explained. Case scenario 4. A 45 years old lady, 85 kg weight, diabetic and hypertensive for the last 10 years, and has failed to achieve her goal of HbA1c of less than 7% with optimal doses of 3 oral hypoglycemic agents. Now, optimal doses, when we talk about metformin, the optimal dose would be 2 gram, 2.5 gram, glimepiride 6 milligram, and SGLT2 inhibitors, empagliflozin 25 milligram, dapagliflozin 10 milligram. So these are the optimum doses. Patient is already on optimum or the maximum tolerated dose of 3 anti-diabetic agents minus injectable, and the decision of starting insulin was deferred to the current visit. That means last time patient also was not on goal and you had suggested to this patient that we need to start insulin, but patient asked for some more time and you deferred the decision till this visit. She recently had a road traffic accident and was transfused 2 pints of blood. and she is taking her full dose of triple oral therapy. And she comes to you and presents her reports, and blood sugar fasting is 170 milligram per deciliter, but she is very excited to show you her HbA1c of 6.8, and her urine protein is 1 plus proteinuria. Urine protein is 1 plus. What do you say? Would you be happy with HbA1c of 6.8, or there is some caveat here? Blood sugar fasting is 170. Patient tells you that he actually took some extra serving of dessert last night, but this fasting sugar was 8 hours plus. What do you think? What is the explanation of disparity between blood glucose and the HbA1c? What do you think? Do you think the decision of starting insulin should be taken, or should be delayed further because she has achieved her HbA1c of less than 7%? I think there's a little catch here. This patient received 2 pints of blood from a healthy donor. That healthy donor must have normal glucose. So that must have lowered HbA1c falsely to 6.8%. Plus, because of the blood loss, this patient must be having very, very rapid hemopoiesis. Many new young cells are coming from the bone marrow, which have not yet time to get their hemoglobin glycated. So HbA1c here is not giving you the right picture. So here we will, I think, base our judgment on fasting sugar. Since this patient is already more than 10 years diabetic and she is already developing complication, there is a definite need to do something to take the next action, and the next action is usually insulin. Of course, if she is on just oral agent, the next action could be an injectable GLP receptor agonist also, but next action should be taken. No addition of fourth oral agent is going to work. I think next injectable has to be started. Or would you rather consider some other injectable therapy? I think according to the new guidelines, GLP receptor agonists, they are to be considered before insulin. Although GLP receptor agonists are expensive, if somebody is more prone to develop atherosclerotic cardiovascular disease, like this patient is, she has got uncontrolled diabetes and she is also hypertensive. So I think ideally, if this patient can afford a GLP receptor agonist, should be considered. Otherwise, insulin would be a great choice. Now, the last case scenario, a 34 years old female has been diagnosed with type 2 diabetes and has come to you for a follow-up. Her reports are as follows. Now, this is the complete lab. Her CBC, HB, this is hemoglobin, not HbA1c. HB 10.2 grams per deciliter. MCV is 65, which is less than expected. That means she has microcytic picture. And RDW, red cell distribution width, is normal. It is 12. It falls within the normal range. That means RBCs are smaller in size because of low MCV, but the variation in RBC size is not much. And her blood sugar fasting is 190 milligram per deciliter. Blood sugar random is 270 milligram per deciliter, and her HbA1c is 6. Now, patient knows that HbA1c is a great test and gives you a better picture than glucose values. She wants to convince you that her sugar is very well controlled, 6%. But how would you ignore these values, fasting of 190 and random 270? And serum iron studies were done because mostly we have iron deficiency as cause of microcytic anemia, and iron studies were negative for any iron deficiency. And another cause of hypochromic microcytic anemia is chronic renal disease, and creatinine was well within normal limits, and there was low albuminuria. What do you say? Why HbA1c looks so normal? Though not exactly normal, it is in the pre-diabetes range, and blood sugar values are in the diabetes range. What is the explanation? I think if you're smart enough, you must have already made a judgment. What do you think is the cause of anemia? It could be iron deficiency or it could be thalassemia. Iron deficiency has been ruled out, and this is most likely a case of beta thalassemia. In Pakistan, we have fairly common beta thalassemia minor. So I think this patient actually has beta thalassemia. So this is a case scenario. To give you an example, that people with beta thalassemia, their HbA1c will not truly reflect their glycemic status. Not to say that their HbA1c is absolutely useless, but every time we interpret their HbA1c, we will consider this factor. So if HbA1c moves from 6 to 7%, that means her glycemic control has become worse. So how do you interpret her HbA1c? I have already explained. And how will you assess her long-term glucose control? Bad, because blood glucose values are fairly bad. So summary points: HbA1c is a great tool for the diagnosis as well as monitoring and the treatment of diabetes, with some caveats. Once somebody's HbA1c is 6.5 or above, even single value, that makes the diagnosis of diabetes. And once a diagnosis of diabetes is made, we try to bring it back to at least 7%, ideally to 6.5%, and in the most ideal situation, maybe less than 5.7%. But I think current therapies just allow us to keep it less than 7 and maybe somewhere in the safe zone. So that was a brief introduction of interpretation of HbA1c. So that is all about interpretation of HbA1c. I hope that this talk was useful, and I really look forward to see you in my next video. And I'm Professor Azizur Rahman from Medurstand, Understanding Medicine. Thank you.